So welcome each and everyone to another session on gastro disorders. So in the last class, we began with the gastro assessment, isn't it? So some of the disorders we covered, like mainly cirrhosis of liver, GERD, esophageal varices, and I believe you would have reviewed something on the same. And let us continue today with the remaining disorders of gastro. Fine. So the first topic that we are going to begin with is on hernia. See, hernia mainly we are going to discuss about hiatal hernia as well as inguinal hernia. Okay, so hiatal hernia in the sense, what do you understand? Like hiatal hernia is something or hernia, when do you usually say hernia? Or what do you understand when you know that somebody has got hernia? So what does that actually mean? So what's the actual problem there? Any idea? Yes? What's the actual problem there? Yes? Yeah, something is, so the muscle is actually muscle, or sometimes it can also be the underlying tissue is something, it's bulging or it's coming out, isn't it? So that is something we can call it as hernia. Okay, like by here, so basically hernia, you can see the picture here. So normally in diaphragmatic hernia, so this is how it looks. Fine. So whereas, so in the case of hiatal hernia, so the portion peeps out through the diaphragm and it can move into the thoracic region also. Sometimes it could be sliding, okay, or in the sense both the side you will be finding some perforation, fine, or else sometimes it could be just rolling also. So it again differs. But whatever it is, knowing the important signs and symptoms are so it's very essential. Like, how do you understand a client could be having hernia? Any answer before I show this slide? So any answer? How can you think, or what could be the symptoms? Yes. Pain. What sort of pain? Where is the pain? Pain in the
abdominal pain. Pain.
So will there be pain?
Lower abdominal pain.
Lower abdominal pain. Do you think so? Pain is obvious there?
No.
Yes. Can it be the initial signs?
No.
Yes. No, pain is not that obvious in the case of hernia. But mainly, what can you see there? So the client will be complaining, pain in the sense it is much more mild. Okay, so pain is not something we are going to focus more here. So whereas there are other added symptoms that you need to know. It's not severe pain, as you know. Yes, there is reflux or heartburn you find. Okay, the client will experience some discomfort, and the discomfort will be more especially when the client does some straining activities. Okay, so if he lifts any heavy object, or if he's bearing down during bowel movements and all, so you will find that pain or the mild kind of discomfort. And of course, heartburn is the primary problem that you need to note here. So assessment is heartburn, regurgitation, or vomiting. Okay, so the client will feel like something is coming out, or here the reflex, as you said, and some people can even vomit. Difficulty in swallowing, so because a kind of obstruction is felt near the esophagus. Okay, so at the end, so that is dysphagia, and also feeling of fullness. Okay, so these are the main signs and symptoms that you can generally see for the client who are experiencing hiatal hernia. Okay, so now what could be the specific factor in the case of inguinal hernia? Any answer? What happens in the case of inguinal hernia? Inguinal hernia in the sense, where is that inguinal region? Yes, where is inguinal?
Down to the stomach.
Down, so in the lateral aspects, in the groin region, you will generally be finding here. Okay, so in the lateral aspects of the groin, so there lies the inguinal region. Okay, so in inguinal hernia also, so in the groin, sideways of the groin, the herniation, or you find a muscle mass popping out. Okay, and this is very common in case of males. In males usually are having inguinal, the chances in males are more common. Fine. So but inguinal hernia itself is not a problem, but if the client experiences rigid abdomen, or when you palpate there is rigid abdomen, fever, or you need to understand like all the symptoms of bowel perforation if he says, okay, so then that requires emergency management. Okay, so hope you understand inguinal hernia. So sometimes because of this hernia, you know, so what happens, the abdominal bowel can become ischemic, in the sense because of the protrusion of the mass, you know, like I mean the blood supply into the bowel and all can be affected, or even sometimes there could be perforation. Okay, so if that happens, so then that is dangerous. So you need to always remember to note the signs and symptoms. Okay, so if you, a client who is coming with hernia, if you palpate for the abdomen to be very rigid, okay, so if the abdomen is board-like, on top of that, if he is having fever, okay, so then vomiting, so all these symptoms indicates that so there is emergency treatment is actually required. Okay, so do you understand? So now that's the difference between mainly in hiatal hernia. So mainly the client will have heartburn, regurgitation, these problems, whereas in inguinal hernia, the chances of bowel rupture, ischemia to the bowel and all could be very common. Okay, yeah, so that is the main difference that you need to know. What about the management here? So management could be provide small frequent meals, limit amount of fluids taken between meals, in the sense with meals, okay, not between meals, with meals, along with meals. So you need to so while eating food, fluid has to be limited. Okay, so what could be the reason? Tell me, why is this point, or what is the point specifying here? Yes, any answer? Why you have to limit the liquids with meals?
Because of vomiting.
Vomiting can aggravate, and also so
Window
fast
full, no?
filling can happen, isn't it? So that can aggravate the symptoms of hernia. So that's why so liquid has to be limited. Okay, and advise not to recline. All the GERD manifestations management in GERD you had learned, right? So not to recline soon after feeding. Okay, so after having food, so that's because like everything can come out. Avoid straining activities, high fat food. See, high fat food mainly it will delay gastric emptying. Okay, high fat food will delay the emptying, so that will trigger further symptoms. And also the pressure, these are just like GERD management, all the aspects under the reflux disease management, whatever you discussed, we discussed, you know, the same aspects should be applied here also. Okay, so avoiding chocolates, peppermints, tomatoes, caffeine, so all citric acid foods, and also please remember these points. Okay, so they are the important interventions here, so that should be carried out in the case of hernia. Fine. Okay, yeah. So moving to the next topic, see questions. I'm thinking today we will do questions at the end. After finishing all gastro disorders, we will do the questions, because what I feel is when we discuss some topics and based on that, if I do questions, you know, I have noticed that the answers are very clear. I mean, in the sense all of you are able to answer, but at the end, if I ask, I feel so you are forgetting some of the aspects. So at the end, if I put the questions together, so I just want you to retain the information that we are studying throughout the session today. Okay, so that at the end, I want all of you to answer, because all of a sudden when we learn all the topics, you know, certain aspects we will be confused. Okay, so today we will do in that way. Once we finish all the disorders, I will be putting the questions at the end, so that most of you can stay also. In the sense, I don't want anyone to leave the session in between. So that usually doesn't happen, but still if you are on duty and all, for some exceptions I can allow. So otherwise I don't want you all to leave the sessions in between. So let us finish the questions, and after that you can leave the session. Okay, so kindly give your full focus full attention to the topics that we are going to discuss today so that you can answer well at the end. Okay, yeah. The next condition that we are going to discuss is gastritis. So the terminology is very simple. When stomach inflammation is something, we can call it as gastritis. But what's actually happening here? See, the layer of the stomach, okay, so this is getting destroyed. Fine. So in the sense, the acid, see, there is a protective layer or mucosa. So there are certain cells in the gastric tissues, which we can call it as goblet cells. Okay, so these cells, these cells, so these goblet cells keep producing mucus, and that is how, see, our stomach, what's the environment in our stomach? Acidic or alkaline? Acidic or alkaline? Acidic, isn't it? So these goblet cells will keep producing mucus so that the layer of the stomach doesn't get destroyed, in the sense, so it is it's not getting, it prevents from ulceration, the mucus that is produced by the goblet cells. Okay, but because of certain factors, it could be our lifestyle, in the sense, even like, I mean, so may I know what are all the factors, causative factors for gastritis? Yes, tell me.
Smoking.
Smoking. Okay, very good. Then
Non-steroidal anti-inflammatory drugs.
NSAIDs. Very good. Certain drugs. Okay, so then what else? What else?
Stress.
Alcohol intake.
Yes.
Alcohol
Spicy
intake.
food.
Alcohol, spicy, too much of spicy foods. Okay, so stress mainly. So these are all the adding factors for gastritis. So these will keep, so affecting the layers of the stomach, and it will start destroying the tissues. And that is what we can call it as gastritis. Okay, now this, because of this gastritis, the problem is when the stomach is, the layer is getting affected. So there are main problems, which we can call it as, one of the main complication is vitamin B12 deficiency. Okay, so vitamin B12 deficiency. Do you know why? Vitamin B12 deficiency, how it is related, gastritis and vitamin B12 deficiency? How is it related? Any answer?
Villi are affected, they are inflamed, and that's why vitamin B is not
Okay.
absorbed.
Fine.
And intrinsic cells are affected.
See, in order to absorb vitamin B12, what is essential? What is essential? Intrinsic factor. Very good. Okay, so intrinsic factor is essential in order to absorb vitamin B12. Okay, now vitamin B12 deficiency will occur, so mainly when the intrinsic factor is lost. Okay, so intrinsic factor in the stomach should be present, so that will help in the absorption of the vitamin B12. So when intrinsic factor get lost because of gastritis, because of peptic ulcerations, then the absorption of vitamin B12 will not happen. Okay, so if the vitamin B12 doesn't get absorbed properly, the nerve, see, the entire B group of vitamins are mainly required for the health of nerves. Okay, it also helps in producing the RBCs and all. Now, when vitamin B12 deficiency occur, because our body is not absorbing it, so then that deficiency leads to pernicious anemia. Pernicious anemia. Okay, so whereas because of a dietary deficiency of vitamin B12, especially vegan diet. Okay, so vegans are usually vegetarians, isn't it? So they because this vitamin B12 is usually present in non-vegetarian food like milk, meat, in the sense, all the non-vegetarian organ meats, liver and all consist lots of vitamin B12. Okay, so now if the client is having, usually those who are vegetarians, so when they don't eat these foods, so they could be 10 or more chances of vitamin B12 deficiency can happen in them. Okay, so in that case, it can lead to megaloblastic anemia. So dietary deficiency basically leads to megaloblastic anemia. Okay, so where the cells become large, okay, macrocytic we say. So the cells become large there. So that is vitamin deficiency, B12 deficiency. Okay, so I'm in the sense you need to understand the symptoms of vitamin B12 deficiency also. There will be dizziness, high temperature, mood changes. Okay, so changes in mobility, sometimes skin becomes pale, the tongue becomes beefy, red in color, vision gets disturbed, sensation of pins and needles, stinging sensation in the hands, in the legs and all. So these are some of the added fact or the features that you generally, paresthesias of hands and feet. Even there could be disturbance in gait and balance. Okay, so then the client should increase. See, if the client has got loss of intrinsic factor, then lifelong vitamin B12 injections should be taken. Okay, if it's because of dietary insufficiency, the dietary modifications will help in treating or bringing or solving this problem. Okay, yeah. So that's about why. See, because why this is important is because this happens in most of the gastric disorders, in gastritis, in peptic ulcer diseases, and also after resection of stomach, which after jejunostomy, okay, or after duodenostomy and all. So this problem can occur. So I want you to know these aspects under vitamin B12 deficiency. Okay, yeah. So now gastritis also can cause vitamin B12 deficiency, right? Okay. Now this gastritis, further discussing more, if I have to add on, see, gastritis can all of a sudden, gastritis is something we can call it as acute gastritis. Okay, so there is, and when these symptoms, acute gastritis in the sense, usually the client will always have a kind of reflux, heartburn, always heartburn. Okay, sometimes hiccups also. So when these regulars continuous and in the sense like a later stage, okay, when these acute symptoms are more common, so later stage, the client can end up in chronic gastritis. In chronic gastritis, there will be vitamin B12 deficiency. Okay, so the client will have even belching, always belching. If you note people having belching all the time, or they could be having gastritis. Okay, yeah. So these are some of the symptoms so that you need to know under gastritis. Dietary modifications, lifestyle modifications are the basic ways through which we can manage this condition. Okay, so gastritis. Moving to the next condition, peptic ulcer disease. See, while I'm discussing these conditions, if you feel that anywhere you are actually losing the track, please let me know. Okay, so I will be discussing, I will be stopping that. And if you feel that I'm very fast in discussing, or if you're not understanding the concepts, so please let me know. Okay, yeah. So moving to the next condition, that is peptic ulcer disease. So what happens in peptic ulcer? As I already told you, so there are, so certain cells which we can call it as goblet cells. Okay, so these goblet cells are basically responsible for maintaining the stable environment in the stomach. Okay, these because they keep producing the mucus. Okay, so the goblet cells will produce mucus. I have a picture here I can show you. See here. So now these are the goblet cells. Hope you can see. Fine. So they keep producing mucus. Okay. Now the main cause of peptic ulcer disease is H. pylori bacteria. Okay, H. pylori. This H. pylori, what does it do? So this damage to the cells yeah, so let me get back to what I was discussing. See, I was talking about these goblet cells, that is in peptic ulcer disease, how the goblet cells are helping in production of the mucus and how the Helicobacter, okay, so is destroying it. The H. pylori is destroying it. So as it destroys the layers, you know, the mucus, this Helicobacter bacteria would be releasing an acid. Fine. So this acid is actually destroying the mucus producing cells in the goblets. Fine. So that is how, so when mucus is no more produced in the stomach lining, so then what will happen? So it will result in ulcers. Okay, so it will result in ulcers. Now these ulcers are basically two kinds that you need to know. One is gastric and another one is duodenal. Okay, so this is gastric and this is duodenal. See, this is duodenal, duodenal in the sense in the duodenal region, gastric in the sense here in the stomach region. Okay, so these ulcers are something we can call it as peptic ulcer. Fine. But there are some characteristic features here so that you need to understand. So this is duodenal. These points are related to the duodenal. Okay, so I think the picture has covered the duodenal heading. Okay, so coming to the main differences between gastric and duodenal, you need to know this. See here, so based on the location of the stomach and duodenum, the pain also will differ. The clients will experience sharp pain. Okay, so sharp pain, and these pain differs from left to right here. Okay, like in the gastric in the sense, you know, in the last class I had talked about the food retention time after you take it. Okay, so usually in the stomach, what's the duration or what time does the food retain after you eat? Maximum
60 minutes.
60, yeah, 60 to 1.5, maximum 60 minutes. Okay, 60. Sometimes if the high fatty foods are there, so it can stay up to 1.5 hours also. Okay, now during this time, like soon after intaking food, so if the client within half an hour, if the client is getting symptoms like burning, too much of stomach pain and all that start from the left region, so then that is something we can call it as gastric ulcer. Okay, so whereas if the client complains of or after eating food after 4 hours or after dinner in the middle of the night, the client is waking up with severe stomach pain, usually radiating to the right side, so then that could be duodenal ulcer. Okay, so that is duodenal ulcer, because by the time after 3 hours, after 2 hours, the food moves to the duodenum, isn't it? So at that time, if the symptoms are seen, so then that is duodenal mostly, whereas gastric is soon after in eating food, if the client experience symptoms, so then that is related to the gastric. Okay, when you eat the food, like when you ingest, the pain is more here. Okay, so whereas when antacids are taken, so usually the pain and all is actually less here. Okay, so that is in the case of duodenal. So that is what you need to know. Apart from that, see, there will be bleeding, in the sense gastro bleeding is there. I want you to remember bleeding is very common in both the conditions. In gastric also there is bleeding. In duodenal also there is bleeding. Because ulcer in the sense, obviously there is bleeding. But the bleeding is more common through in the form of vomitus. I mean, so in the vomitus, the blood if it's more, so then that is basic because of the gastric ulcer, because gastric region or the stomach comes under the upper gastrointestinal system. So vomiting would be more commonly seen, and blood in the vomitus, which we can call it as hemitemesis, is very common in the case of gastric ulcer. Okay, so whereas in duodenal ulcer, usually if the client is having duodenal ulcer, so melena is very common, like melena in the sense blood in the stool. Okay, so that is very common. But see, it doesn't indicate, but I remember, so it doesn't indicate that the client will not have a hemitemesis in duodenal. The client will also have hemitemesis. Okay, so whereas more common is melena. So these all options can confuse you. Okay, in the questions when it is given, you know, so they will sometimes mention the client having symptoms of gastric ulcer, and they may give there under the option melena. So you should not ignore it. Rather, you should select it. Melena also can happen in gastric ulcer. Okay, so that's how, but more common what is that's been explained here. Fine. Okay, now, so there are certain other added points also that I want you to remember. So if the client is experiencing, I told you the pain begins from left side or right side depending upon the symptoms. Okay, whereas if the pain is going to back, okay, in the back, if it's radiating, if the pain is radiating to back, so then that can indicate perforation. So this is a very important point. Please note this. If the pain is radiating back, so then that can indicate perforation. Not only that, if the client is having too much of abdominal pain, the pain across the abdomen also indicate perforation. See, when there is perforation, so the pain will be spreading around the abdomen. Usually for gastric and duodenal, one side, like left side or right side, the pain will be there. If the pain is across, all over the abdomen, very severe pain, okay, so then that indicates what? Perforation. Is that clear? Okay, yeah. So moving to the next aspect, there is another syndrome called as Zollinger-Ellison syndrome. This is also one of the causes for peptic ulcer disease. Zollinger-Ellison syndrome, that is combination of peptic ulcer, hypersecretion of gastric acid, and gastric tumors. So this is one terminology, the syndrome, what it is. If suppose if you get in the exam, you need to know what is Zollinger-Ellison syndrome. Zollinger-Ellison is peptic ulcer with too much secretion of gastric acid and gastric tumors also if it's there. So then that is called as the Zollinger-Ellison syndrome. Okay, yeah. So moving to the risk factors, because always NCLEX focuses on risk factors. See, knowing the risk factors for every conditions are important. Okay, because being nurses, so at the end, when the client gets discharged, client education you have to provide. The health education, what are the 4 important responsibilities of a registered nurse? Teaching, assessment, planning, evaluation. TAPE, remember TAPE. Okay, so teaching you have to do, you cannot delegate it to anyone. Okay, you cannot delegate the teaching responsibility to LPN. The first time teaching only you have to provide, whereas the LPN can actually explain, the enrolled nurses can or reinforce once again. Whereas the initial teaching should be done only by registered nurse. The initial assessment of your client should be only done by you. The interventions that has to be planned for every condition should be by you only. Okay, so an evaluation should be by you only. So these are the very important roles of a nurse. So only if you know the risk factors or the triggering factors of every condition, so then that will be helpful under health education. Health education based questions also you keep getting. Okay, yeah. So now under here risk factors, I told you already, H. pylori infection, then drugs like NSAIDs. Like under NSAIDs, what all comes? You have a good idea about that, like all ibuprofen, diclofenac. So mostly all painkillers. Okay, so they come under NSAIDs. So and even sometimes steroids also. So please add on this point too. Not only NSAIDs, so even steroids too. Okay, can cause these problems. Yeah. So just yeah. Then diet, caffeine, alcohol, spicy foods. Okay. So alcohol consumption, stress, genetics, smoking. Okay. So these are all the family history of peptic ulcer can also be a contributing factor for the same. Fine. So these are all the important factors that you need to consider as risk for peptic ulcer disease. Okay. So is that clear? Yeah. So moving to the next aspect. Now you came to know about these aspects. Now what can we do here? Like, but how this is identified or how the client's peptic ulcer is known? Any idea? Any idea? How do you identify peptic ulcer disease? Through what test?
Endoscopy.
Endoscopy, very good. Okay, so mainly duodenoscopy is done. Even the duodenum has to be visualized, isn't it? So mainly duodenoscopy has to be done. Apart from that, so there is also another test which we can call it as urea breath test. Okay, so urea breath test. So urea breath test, in the sense, what is done here? Any idea? Esophagoduodenoscopy and urea breath test. So these are the very common tests that are usually done. Okay, so for urea breath test, usually the client will be fasting for 1 hour. Okay, but before these tests is done, you need to remember some of the medications the client has to avoid, like antibiotics, proton pump inhibitors, any bismuth preparations, misoprostol. Okay, so those medications have to be avoided. Right? So because if these medications are given, so then that will give a false history, a false result of the urea breath test. Okay, the client will be blowing his breath into a balloon, and that breath sample is further investigated. Right? So like previously it was done a lot, whereas now it's not usually done. Whereas this is also another test under the diagnostic that you need to know. Fine. Okay, yeah, so that is something about the urea breath test, but I want you to remember these aspects before urea breath test. This is a very important point for NCLEX. Checking the medication history is needed. Is that clear? Yeah, okay. Moving to the basic nursing care for peptic ulcer. So avoiding the risk factors and monitoring bleeding is very important. Okay, so monitoring bleeding in the sense, why monitoring bleeding? Tell me, what will experience, or what will the client be experiencing there if bleeding is not monitored? Yes, what changes you will be finding in the vital signs?
Tachycardia.
Increased pulse.
Yes, increased pulse, very good. Then what about the blood pressure?
Hypotension.
It drops.
Hypotension, very good. Okay, so hypotension, yeah, hypotension. So this is a very important vital signs. I mean, so that indicate vital sign that indicate client can go into shock if bleeding continues. Fine. So therefore, monitoring bleeding. So you can monitor bleeding mainly by checking for blood in the stools, vomiters, very importantly by checking the vital signs. Okay, yeah, so then avoid smoking, alcohol, all the triggering factors should be avoided, and these are the commonly given medications. Like H2 receptor antagonist, proton pump inhibitors, antacids, mucosal protectants. Okay, but there are different ways how it is given. So some combination medications are there. Like we call it under, we put it together as dual therapy, triple therapy, and all. So in the Friday session, I will be explaining about these therapies of peptic ulcer disease. Okay, so the medications, how it is given. Fine. So antacids, like about all those medications, we are going to discuss separately under the medication section. Fine. Okay. Now, so as of now, you remembered like these are some of the medications that are given. So then, if through these medications, the symptoms can be reduced to some extent, but not great extent. Now, some cases, severe cases, will have to undergo surgery. Surgeries are of different types. Gastrectomy is there, where portion of the stomach or part of the, so all stomach part is completely removed. Antrectomy is there, the antrum portion of the stomach is removed. Okay, and then the gastro, in the sense, the reconstruction surgeries, which we can call it as Billroth 1 and also Billroth 2. Fine. So what is there in Billroth 1? So you know that in Billroth 1, so these are some of the surgeries. So you can see here, the duodenum is removed. Okay, so then the portion of the stomach is removed, and then that is connected to the duodenum. Okay, so the portion of the stomach where ulcer was found, so that is removed and we connect it to duodenum. And in jejunostomy, so you can see here, so the again the where the duodenum is removed, and then so to the jejunum it will get connected. The stomach is connected to the jejunum. Fine. Okay. So and here also, so mainly, so these come under the antrectomy procedures. The antrum is the lower part of the stomach, so which is removed. Fine. Okay, so that is what is done here. So apart from that, so there are also other surgeries like vagotomy, pyloroplasty, and all. So what is done here? Vagotomy. The nerve fibers. Vagotomy in the sense vagus nerve is manipulated there. How it is done? In the sense, what is done there? So vagus nerves that produce too much of acid, you know, so that is disrupted. So the vagotomy nerves are actually selected and manipulation is done so that the high production of acid gets disrupted. Okay, so that is what is done through vagotomy procedure. Fine. So apart from that, pyloroplasty. Pyloroplasty in the sense the pylorus. You know what's pylorus, isn't it? So this part of the stomach. In the sense, this part is something we can call it as pylorus. Pyloroplasty. So that part is widened here, widened, because so that we can speed up, or sometimes we can make sure that the gastric emptying can happen fast. Okay, so that is what is done here under pyloroplasty. The opening between the stomach and the small intestine where pylorus is there, so that opening is enlarged so that the gastric emptying can be increased here. So here, when a client is experiencing peptic ulcer disease, so as long as the food retains in the stomach and in the duodenum, the symptoms will be very severe. So you need to focus that. So especially if a client is having gastric ulcer, for him pyloroplasty is done, so that when that pylorus is broadened, you know, so the food will move fast. It will not stay in the stomach for a longer time. The food will move fast and that will be entering into the duodenum. Okay, so that is why these pyloroplasty procedures are usually. Is that clear? Okay, yeah. So, and of course, after surgery, you need to check for infection. So that's very important for every procedures. Semifowler's position, NG tube monitoring. So this is important here. See, initially there will be bleeding for up to 12 hours and even up to 24 hours, scant blood if you are seeing. So that is normal. Okay, so nothing to worry about that. So that is absolutely normal. So some scant blood can be seen in the first 12 to 24 hours. Okay, yeah. You need to monitor for the bowel sounds. The bowel sounds should be there. You need to check for the bowel sounds. Okay, and the diet can be increased based on how the client tolerates. So based on that, if the client is having diarrhea, so you need to reduce all the high fiber diet and all those things based on how the client's condition is for every person. So the dietary aspects differ here. So because based on each person's body, you know, the diet can be changed, and the diet based on how each person tolerates. So based on that, it is provided. Okay, so then we give all the analgesics, vitamins, mineral supplements, because after gastrectomy, especially vitamin B12 and all will be reduced, especially the B12. The absorption gets affected. Okay, yeah. So somebody's talking there. Yes. Okay, I'll just try to mute. Fine. So do you have any doubts? So then you can talk, but I found it was the mic was on, and yeah, so I have just muted. Okay, so what I was telling was about these medications, isn't it? So especially vitamin B12 absorption gets affected. Hope you can link what could be the reason, the initial part, what I had explained in the beginning of the class. So because the intrinsic factor will be lost there. Okay, yeah. And also too much of carbohydrate should be avoided. What could be the reason for this? Any answer? Why usually carbohydrates are avoided? Yes? Carbohydrates, what does it do? No, carbohydrates digest fast. Carbohydrates doesn't take much time to digest. Too much of carbohydrates. Any other answer?
Sugar level increase, chance of getting sugar.
Increases, there will be high production of insulin. Yes. Then healing time. I'll come to this part. So it depends on the explanation in the next part that I'm going to give. Okay, so next I'm going to discuss about a complication. So there you will understand. So why here, even after this surgeries, large quantities of carbohydrates are avoided. Okay, so I'll come to the complications of after the peptic ulcer surgeries. Okay, so hold on now. Yes, moving to the next one, complication. The first complication is perforation. So this is very important. Okay, so because when the suture can get perforated, how do you understand perforation? All the symptoms of perforation. So you have already learned, like rigid board-like abdomen, hyperactive to diminished bowel sound, rebound tenderness. So what is this rebound tenderness? What's rebound tenderness? Yes. What's rebound tenderness?
It's like knots.
No. So usually pain in the abdomen. Okay. So pain in the abdomen, but this pain, you know, will be more common. So no, see, usually when you palpate, the client will be having mild pain, but the pain will be more when you remove your hands, from palpation. Okay, so that increases pain. Like actually when you palpate, the client will experience mild pain, but when the moment you withdraw your hands, you know, the pain will be more severe. Okay, so that is something we can call it as a rebound tenderness. Is that clear? Okay, so this is also called as Blumberg's sign, BLUM. Okay, so I'll just write it down for you, just for your added knowledge. That's it. Blumberg sign we generally say. Fine, so Blumberg sign. So usually when the hands are removed after palpation, the client experiences pain. Fine, okay, yeah. So then apart from that, yeah, so then vitamin B12 deficiency. Remember perforation. See how you get questions in NCLEX? You get questions like the client who had undergone peptic ulcer, or they will specify the name, Billroth 1 surgeries or Billroth 2 surgeries 4 hours before, or they give the scenario like you are caring for a client who has undergone Billroth 2 surgery 4 hours before, and on assessment, so the client has a pain scale of 8. Okay, so and you find that the 8 and rebound tenderness and etc. they will be giving. So what will be your immediate action? So that will be the question. Okay, so immediately what are you supposed to do? So you will have to call or notify the doctor. Fine, so notify the physician. So that's very important here. Fine, okay. And so, and also they will give some, the questions can change. So what would be the or which finding indicates emergency? They can or what other finding can indicate emergency? So in that case, if there is any option like hypotension, tachycardia, and also you have to select that, because they are the added symptoms of shock. Because when there is perforation, the client can go into shock, isn't it? So this is how you need to critically think for a, so here, okay, so how you have to critically think. Okay, yeah. So about carbohydrate, I'm coming to explain in the next complication, that is dumping syndrome. Dumping syndrome. This is another complication of peptic ulcer disease that you need to know. Not only peptic ulcer disease, so after gastric resection surgery. Okay, so after gastric resection surgeries, so the complication, one of the other important complication is dumping syndrome. Okay, yeah. Dumping in the sense what? When you look at the picture, what do you understand here? See, there is loading of food or the food is falling into the duodenum. They have written there high carbs, high fluids, directly flush in or moved into the duodenum. Yes. So what's happening here? Any idea of dumping syndrome?
Gastric emptying is faster.
Yes. Very good. The gastric emptying is becoming very, very fast here. See, the stomach portion is removed, isn't it? The portion of one portion of the stomach is removed. So in that case, so what's okay? The food is not retaining inside. So fast it is moving to the abdomen. Okay. So as it moves fast, the client will experience too much Yeah, so I'm here to show another picture here. This was the picture that I was sharing on dumping syndrome. Okay, so dumping syndrome. So now is my voice clear now? So I can see some messages saying my voice is not clear. I believe it is clear now. Yeah, isn't it? You can see the slide, right? Okay, fine. So this is what we can call it as dumping syndrome. Okay, I was explaining about the dumping syndrome. But for exam, you need to know the, so the signs and symptoms of dumping syndrome. Okay, so that's very important here. So under dumping syndrome, so initially this occurs, the time limit you need to know. Fine. So within 30 minutes and all, if the client experiences nausea, vomiting, they can be considered as the initial symptoms. They are the initial symptoms of dumping syndrome. Okay, under the initial symptoms, the client will be experiencing nausea, vomiting, tachycardia, palpitation, and all. Okay, but after, there are some late manifestations also that you need to know. Under late manifestation, see, you need to now think here. Now I'm going to relate with that of the high carbohydrate diet. Why you should avoid after gastric surgeries. Okay, see, the moment you take high carbohydrate diet, you know, so carbohydrates, simple carbohydrates, especially milk, sugar, and all, will speeden up or fasten the gastric emptying. Okay, so you would have noticed, or you can even after you eat or after you have a candy or rice. Okay, after you have rice, after you have candy and all, so you feel or you will be hungry very quickly, isn't it? So then when you, after you eat some heavy or the food that was made up of wheat and all, so that will stay there for a little more longer time, isn't it? So you don't feel that hunger. Fine. So now after you eat rice or after you have a chocolate and all, you feel that you have not eaten anything, or sometimes you will have a craving to eat again and again also sometimes. Okay, so now that happens when you especially eat chocolates, whereas that is related to something else, where when you eat chocolates and all, you know, happy hormones gets released and they will ask you more and more. So that theory is something different. I don't want to bring it there here now. So whereas here what happens is the high carbs, high fluids and all, you know, they increase the gastric emptying. Okay, and fast the food will be moving to the duodenum. Now when duodenum gets very rapidly food, what will happen? High insulin gets released. Okay, so there is a release of lots of insulin. Fine. So release of lots of insulin, and this high levels of insulin will try to lower the in the sense, it will be the excessive insulin release will work on the food, and thereby the client's blood sugar level can also go down here when excessive insulin gets released. So soon after, in order to avoid the release of excess insulin, you know, so you have to advise to avoid carbohydrate rich diet. after gastric surgeries. Is that clear? Okay, so especially all the foods like that consist of simple sugars, rice, milk, what else? Juices, fine. So all those have to be avoided. Do you understand? Okay, so fruit juice, any sweetened fruit, honey, jellies, and all should be avoided. Whereas rather what food you should focus? You should focus the client to eat a high protein diet, high fat diet. Okay, so high protein, high fat, and low fiber diet. Write down the diet. Okay, so the dumping syndrome, in order to prevent the symptoms of dumping syndrome, the client should be eating high protein diet, high fat diet, low fiber diet. Carbohydrate should be very minimum in the diet, because we do not want the food to be emptied very quickly. So here, let me also, I want you to add on another aspect also. You should not be getting confused here. In hiatal hernia and GERD conditions, what did we discuss? The opposite food should be carried out there, isn't it? We want the food to be emptied fast there. In hiatal hernia and GERD, okay? So what did we discuss there? So I asked you to encourage high fiber food, isn't it? Okay, so whereas because the more time the food retains, the more symptoms, the reflex symptoms will be more. So that's why in those conditions we want the food to be moved quickly to the duodenum, right? So I mean, so the gastric emptying should be fast. Whereas here, after peptic ulcer surgery, remember, after peptic ulcer surgery or after gastric removal surgery, procedures and all, the dumping syndrome can happen. So therefore, so you need to focus on delaying the gastric emptying. Please be very clear in understanding these concepts. I don't want you to be confused. Is that clear? Okay, so no high carbohydrates, no bread, potatoes. These all are high in carbohydrates that will rapidly move to the duodenum, releasing excess insulin. And when insulin is released in excess, you know, soon after 1.5 hours and all, the client will feel confused, hunger, dizziness. All symptoms of hypoglycemia can happen. Okay, hypoglycemia can happen. So therefore, so early manifestations of dumping syndrome is nausea, vomiting, dizziness, tachycardia and all. There are some late manifestations also, like hunger, dizziness, shakiness, confusion and all. They are the late manifestations of dumping syndrome. Is that clear? Yeah. Okay, so shall we move to the next aspect? Yeah, so these are some points that you can note down, so which we already discussed. Like lie down after a meal, limit the amount of food ingested at one time. Okay. Eliminate liquids with meals. Consume high protein, high fat, low fiber, low to moderate carbohydrate diet. Avoid milk, sugars, sweets, milkshakes, etc., etc. Consume small, frequent meals rather than large meals. Yeah, let me also say one more aspect here. Eliminate liquids with meals. Okay, so in the sense, while you are taking food, you should not take water also. That's wrong. Okay, because the food will move quickly to the duodenum. While you take food, you should not take water. Rather, so if there is an option called as have liquid between meals, then you can select this. Between meals, you can select as the answer. Okay, not with meals. Between meals. Between meals in the sense what? Between morning and afternoon meal, you can have water. Okay, with meals is wrong. Is that clear? Hope you are understanding. In any ways, if you're not understanding, please let me know. Okay, I can't, because you're 50 of you are there and I can't call each of yours name to ask whether you have understood. So if any of you are not clear with these aspects, please let me know. Okay, yeah. So moving to the next aspect is, that was all about the peptic ulcer disease, its complication. Okay, I believe you are clear on those aspects. Moving to the bariatric surgery. What is this bariatric surgery? Any idea?
It's for obese patient to help them lose weight.
Exactly. Okay. So bariatric surgery is usually done for obese clients. So obese clients in the sense mainly those who are having too much of abdominal mass in the sense like when size of the stomach is very too much. Okay. So in order to reduce the size of the stomach, mainly these bariatric surgeries are done. But bariatric surgery is actually a very complicated one. So these are the different ways through which these surgeries are done. Gastric bypass, you can see here, the esophagus bypasses the stomach and this portion is removed. The sideways sleeve gastrectomy we say. Gastric banding procedure are also there. But this causes lots of complications. I know a few who have died because of the surgery also, because of thromboembolic complications. Okay, so death is very common. So these bariatric surgeries. But for the ones who are successful in these surgeries, there are some points which you can bring in your teaching. Again, like almost the similar aspects in regard to the dumping syndrome, like small meals. Okay, so drinking fluid separately, not during in between with the meals, separately. Okay, so multivitamins have to be taken because they also will have vitamin B12 deficiency. Is that clear? Okay, so yeah, so these are some of the points under the bariatric surgery. Okay, yeah. Now we have discussed a few conditions. Now let me focus on the questions based on the conditions that we have discussed. Yeah. So just okay. So here is the first question. The nurse will implement which nursing actions when caring for a client recently diagnosed with hiatal hernia? SATA question. See, whenever you do SATA questions, don't overanalyze. If you overanalyze, you end up in wrong answer. Understand what the scenario is asking. The nurse will implement which nursing actions, in the sense you have to carry it out. Okay, for a client who is having hiatal hernia. So what are the actions? You learned about hiatal hernia, isn't it? So what did you learn there? So what are the actions that can be given? Just think in that way, whether it is okay to provide. Consider each option separately and think whether it is okay for hiatal hernia and then give the answer. Okay, I want all of your answers in the chat box. I appreciate all of your answers. After hiatal hernia, elevate the head of the hospital bed. Is that fine?
Yeah.
Yes, ma'am.
Yes, it's fine, isn't it? Okay, so there is nothing to worry. Like, of course, head end can be opened or elevated to 30 degrees. Okay, it can even be done by, so instead of elevation, sometimes they will give use pillow, 2-3 pillows and all they will include in the option. Yes, that's right. Instruct the client to avoid tobacco and caffeine.
Yes.
Yes. Offer small, frequent, low-fat meals.
Yes.
Yes, ma'am.
Provide a girdle to reduce the hernia. What's girdle? Girdle in the sense? A binder. isn't
Yes,
it? So can you give that?
No, no.
That will increase what it will increase pressure. You should, what did you learn? See, in hiatal hernia, you learned that all the aspects of raising the pressure should be avoided, isn't it? So all strenuous activities, even tight clothes and all should be avoided. And when girdle is put on, so the intra-abdominal pressure goes very high. Okay, so therefore, so this option has to be avoided. Okay. What about the fifth option? Yes, fifth option is
Yes.
very clear. Yeah. So congratulations to those who have answered right. Very good thinking. Okay, so hope others have understood. Those who went wrong also. So you need to learn through every mistakes. Okay, where you went wrong. And this you should remember so that you can apply in the next set of questions when you practice. Moving to the next one. The registered nurse is supervising a graduate nurse, providing post-operative teaching for a male client after an inguinal hernia repair. Get back to the question. So you are supervising a graduate nurse, and this graduate nurse is providing teaching for a man who underwent inguinal hernia repair. Okay, so these aspects you need to know. Under the settings, you should under the scenario, all these aspects you should underline. Okay, the clue words you need to underline. Now, which statement by the graduate nurse would cause the registered nurse to intervene? Means what? So there is one wrong statement said by the registered nurse, sorry, the graduate nurse, which should not be followed in this condition. What is that wrong statement?
Second one.
Second one, yes, isn't it? So that was a really an easy aspect. The second one is the right answer. Okay, so you know why this is fine. So and that's why second one is considered as the right, whereas other aspects are okay. So you can elevate, you can ask the client to elevate scrotum and apply an ice bag to reduce swelling. Okay, so this is fine. See, ice bags, when it is applied, you should also focus that. So ice bags are not applied continuously. Okay, so if continuous ice bags are applied, what will happen? So that can cause vasoconstriction and okay. So apart from that, so you can educate on these aspects. Scrotal support ice packs will help in decreasing the pain, and also the scrotal swelling will get decreased. Okay, yeah. And like output should definitely be monitored, you know that. And also like all the aspects under post-operative complications to be prevented. Like, so when you ask the client to turn in bed, perform deep breathing and all, that will help in preventing the post-operative complications. Okay, and that's why, whereas one thing that is wrong is straining. So coughing, clear secretions and all come under straining activities. Okay, so no straining activities can be recommended here, and therefore option 2 is the right answer. Okay, yeah. So moving to the next question, I'm just opening the next question. Yeah, so this question I have specifically put here because yesterday in the Monday session, while discussing about the nutrition, I forgot to mention one aspect, one important aspect. So that I will be explaining after once you do this question. The hospitalized client with anorexia nervosa is started on nutrition via enteral and parenteral routes. Okay, which client assessment is the most important for the nurse to check during the first 24 to 48 hours of administration? Whether it is albumin level and body weight, potassium and phosphate, symptoms of dumping syndrome, or WBC and neutrophils. See, just don't blindly, you have learned that albumin is needed for checking the nutritional status. Yes, I'm not saying no. Fine. So get back to the question again. The hospitalized client is started with anorexia nervosa means what? Anorexia nervosa. Any idea about this condition?
Patient is
It's
obsessed
eating
with
disorder.
losing weight.
Eating disorder. Yes, it comes under eating disorder where the client will be on fasting for a long time, isn't it? So she has a fear that she becomes obese. Usually it's very common in females in teenage groups. She has a fear, and there could be a psychological stressful factor also behind these behind these aspects. Okay, so now after a long period of fasting or without eating and all, the client will then be started with the nutrition. Now in that case, initially when she is fed, okay, or when she started with nutrition, so what should be the important, the question focuses on most important for the nurse to check during the first 24 to 48 hours. The question is very specific. What should be the most important aspect here? The answer?
Number 3.
Number 3, why? Number 3, why? It's not number 3. Rather, it's number 2. Okay, number 2 is the right answer here. I'll explain why. See, when a client, this is not only for anorexia nervosa, for all clients who are on long-term after fasting or after not eating anything and all, you know. So when the client is started with feeds, what you need to mainly focus is the client can experience a fatal complication. That is something we can call it as refeeding syndrome. Okay, so please write down refeeding syndrome. That is a fatal complication. So that can arise for malnourished clients who are started with the feed again. Okay, so now you need to understand that usually chronic malnutrition makes the pancreas to produce less insulin, isn't it? So now when suddenly food is given to the client, or when IV fluids are given to the client, insulin secretion will start to rise and rise. When insulin secretion starts to rise, you know, the phosphorus, the potassium, the magnesium, see all these times, so these electrolytes were out, and now when suddenly when insulin started working, there is sudden shift in the electrolytes intracellularly. Okay, see, phosphorus was the electrolyte that was mainly lacking for those who are, because phosphorus is required for giving the energy, which converts to ATP, adenosine triphosphate. Okay, so that is needed for energy. Now phosphorus that was lacking, when insulin started its action, suddenly it will enter inside the cells. Okay, and this will cause what happens, and all these levels, sudden shifts in the phosphorus or sudden shifts in the electrolytes will cause cardiac dysrhythmias. When electrolytes totally change all of a sudden, you know, the client can have cardiac dysrhythmias. Okay, so therefore, so when a client is aggressively initiated with nutrition without making sure about the electrolyte requirement and all, so then that can end up in a fatal complication, which we can call it as refeeding syndrome. Okay, so refeeding, therefore people who are chronically malnourished, when they are beginning with the new feeds and all, you should mainly monitor their electrolyte values. Is that clear? Okay, so therefore more importantly, serum albumin and all is needed. I do agree with that. So albumin is needed to check whether so whether the nutritional so whether the nutrition therapy was successful or not. So that can be done at the end also. Okay, but here, so what can prevent this complication? Only when you check for the electrolyte levels during the first 2 days, then that will prevent the occurrence of refeeding syndrome. Okay, so that's why. So this is in order to prevent refeeding syndrome, monitoring this is very important. Is that clear? Okay, yeah. So we'll move to the next question. Okay, so this comes under the late. Somebody's mic is on. Please mute your mic. Okay. We'll come to this question now. A client comes to the clinic for a follow-up visit after a Billroth 2 surgery, gastrojejunostomy. The client reports occasional episodes of sweating, palpitations, and dizziness 30 minutes after eating. Which nursing action is most appropriate? See, focus on every clue terminology. This client is coming for a follow-up visit, okay, after Billroth 2. Now the client reports occasional episodes. In between, there is occasional episodes of sweating, palpitation, dizziness, and this occurs 30 minutes after eating. What nursing action is most appropriate? Check serum blood glucose level for hypoglycemia. Ensure that the client consumes fluids with meals. Take the client's blood pressure while lying and standing. Teach the client to lie down after eating. That's the right answer. Yes. Fourth one, very good. Okay, so fourth one is the right answer here. Some of you gave me the answer as third one. See here, this is why I asked you to focus on the clue points. I marked here also. A client comes to the clinic for a follow. Now he's visiting the clinic, right? Okay, so he's coming for a follow-up visit. When he comes for follow-up visit, he says that is his complaint. Okay, he's reporting that he has occasional episodes of sweating, palpitation, dizziness 30 minutes after eating. So when he says these symptoms, what nursing action is most appropriate? See, why did you select take the client's blood pressure? Is he having now the symptoms? Is he having now? No. Okay, he says he's complaining that usually or occasionally, like at home or after eating, he experiences these problems. Now, when he's having those problems at home, now what is the significance of checking the blood pressure while lying and standing here? Now, how can that be the most important nursing action? Think, okay, critical thinking applies is nothing but application of the scenario, the information in the scenario, what is asked in the question. You learn many things in the classes, in the content and all. You learn a lot of information. You learn many things, in fact. But NCLEX basically assesses how you are able to apply understand the question and apply the same. Okay, the client comes for a follow-up in the sense he's reporting these are his problems that generally occurs after eating. So what can you do now? Right now, when he's complaining, he doesn't have any of these symptoms. Please understand that. Okay, so now in that case, which nursing action is most appropriate? So in that case, if you check blood glucose now, that's of no use. Okay, if you ensure that the client consumes fluid with the meals, of course that should not happen, isn't it? So take the client's blood pressure while lying and standing. No use now, because now he doesn't have any problem. Now he's not dizzy. Now he's not sweaty. They are just his complaints. Whereas only if you teach the client to lie down after eating, so this will reduce these symptoms. Why? Because these symptoms are the indications of what? Dumping syndrome. Okay, so they are nothing but dumping syndrome. Okay, so that's why, so these aspects should be considered as very, very, very important. Okay, yeah. So moving to the next question. The nurse is reinforcing discharge instructions with a client following partial gastrectomy. Discharge instructions. Which of the following instructions should the nurse include to prevent dumping syndrome? To prevent dumping syndrome, so which are the instructions that has to be included? Add high protein foods to the diet, consume high carbohydrate meals, eat small frequent meals, Increase intake of fluids with meals. Lie down after eating. What are the answers? I don't want any of you to make mistake in this silly question, simple question. Yes, most of you have given the answers. Fine, very good. 1, 3, and 5 are the right answers. Okay, see all the aspects you need to focus. Yes, high protein is needed, not carbohydrate. Small frequent meals, yes. Increase intake of fluids with meals, no. Okay, between meals can be considered yes, not with meals. Lie down after eating is also the right answer. Very good. Okay, so 1, 3, 5 are the right answers.
Excuse me, ma'am.
Yeah.
Can you show the question again?
Once. This one.
Yes. Number 3, eat small and frequent meals. How is that going to prevent dumping syndrome?
See.
It does have, yes.
Yeah. Yeah, see this one. Yeah,
No,
so
it-
when you consume slow
Yes.
or when you consume small frequent meals, you know, so that will actually reduce the amount of food in the stomach, isn't it? Okay, so when
Yes.
frequent meals are eaten, the amount of food that retains in the stomach will be reduced. So when little food is there in the stomach, the movement will be slow. Okay,
Yes.
so that's why. So you need to focus on these options. Okay, so when more food is there in the stomach, there is more pressure exerted, and therefore the movement will be fast.
Okay.
Yeah, so that's why. Okay, so that's why 1, 3, and 5 are the right answers. Okay, moving to the next one. The clinic nurse educator is developing a teaching plan for the following 6 clients. Okay, that's what I was checking. Where is the 6th client? The 6th one is sitting here. Okay, so the nurse should instruct which client to avoid the Valsalva maneuver when defecating. Okay, Valsalva maneuver, you know that is nothing but bearing down. So Valsalva maneuver when defecating. Yeah, Navjot has said that the screen is not seen. Is it seen now? Are you
Yes,
seeing
it's
the
visible
screen?
now, ma'am.
Previously it was not visible.
No, ma'am, but now it's visible.
Okay, fine. Okay, so where did it go? 22-year-old man with a head injury sustained during a college football game. 30-year-old woman recently hospitalized for reconstructive augmentation mammoplasty. 56-year-old man, 2 weeks post myocardial infarction. 68-year-old woman recently diagnosed with pancreatic cancer. 74-year-old man with portal hypertension related to alcohol-induced cirrhosis. And this is the 6th one. 82-year-old woman, 1 week post-cataract surgery. Now, you need to think in which clients bearing down or Valsalva maneuver should be avoided. Think Valsalva maneuver is straining. Okay, like wherein you hold the breath, bear down, especially when there is constipation and all, you know. So straining is something we can call it as Valsalva maneuver. So in whom this straining should be avoided? Valsalva maneuver is recommended for cardiac dysrhythmias, okay? Because when Valsalva maneuver, when the vagus nerve, through Valsalva maneuver, what are you doing? The vagus nerve is stimulated. And when vagus nerve is stimulated, that will slow the cardiac, this one and all. I mean, so the dysrhythmias and all. The cardiac output get decreased and the cardiac complications will be reduced. So Valsalva. But apart from that, the other options, 22-year-old man with head injury sustained during a college football game. Why did you select this? Give me the answer too.
It's to increase ICP.
It will increase the
Increase ICP.
ICP. Very good. Okay, so what about the second one? Mammoplasty, do we have to avoid?
No.
No, it's nice. Yeah, okay. So what about the third one? Myocardial infarction?
No.
Myocardial
No.
infarction? For myocardial
No.
infarction, you should avoid because so it will slow the heart rate. Okay, it will decrease the cardiac output. For dysrhythmia, so you are actually advising about the Valsalva manovus. Whereas for myocardial infarction, you should avoid. Okay, so third one is the right answer. So what about the fourth one?
No.
No? Yeah, that's fine, isn't it? So what about the fifth one?
Yes.
Yes, what will,
Void.
yeah, what will happen there? Straining when you strain,
Increase.
there will be bleeding,
Increase.
esophageal varices.
Bleeding.
Yeah,
That's very-
esophageal varices. So what about 82-year-old woman 1 week post cataract
Yeah.
surgery?
Yes. Intraocular pressure. Increase intraocular pressure.
Yes, exactly, isn't it? So she will be experiencing increased intraocular pressure, and that is contraindicated for cataract surgeries following glaucomas and all. So therefore, very good. 1, 3, 5, and 6 are the right answers. Okay. Yeah. Okay, guys, so that was for the first half of discussion. So now you can take 10 minutes break, and after that we will be continuing with the remaining aspects of gastro disorders. Okay. All of you are back after a short break. We'll continue with the remaining topics. And the first topic of discussion now would be cholecystitis and cholelithiasis. Okay, so cholelithiasis cystitis. Hope you would be knowing what is this. Chole is somewhere we relate it to which part? Gallbladder.
Gallbladder.
Exactly. Okay, so gallbladder. Now here, specifically cystitis, cholecystitis in the sense gallbladder inflammation. Okay, whereas lithiasis in the sense stones could be present in the gallbladder. So that is lithiasis. Now you know the function of gallbladder, right? So what's the basic function of gallbladder? If you know the function, it's easy to assess the symptoms also. What's the function of gallbladder?
Storage of
Just
bile.
wow.
Storage of bile. Okay, so just imagine, so there has been inflammation. So now we have learned about the 9 quadrants of abdomen, and gallbladder could be present in which quadrant?
Left
Right up.
hypochondria.
Right.
Right hypochondria. Right.
Exactly, right hypochondria. So now where you will, like suppose if there is gallbladder inflammation, where you will experience pain?
Right hypochondria.
Right
Right
upper
upper
quadrant.
quadrant.
Exactly. Okay, so remember that should be the first point. Pain in right, these are all based on the thinking. Okay, so right hypochondriac region. So that should be the first point that you need to assess. Okay, where is the pain? The location of the pain. And since gallbladder is located behind, in the sense beneath the liver, it is present, and therefore the pain will not be in front, whereas usually it will be radiating back, okay, towards the scapula. Okay, so towards the scapula the pain will be radiating. So that is because of the in the sense like because of the location. Okay, and when specifically this pain can be aggravated, any idea? See, you know the function. So when the gallbladder has to act, remember, so at that time the
Type food.
Fatty diet,
yeah,
fatty
very
foods.
good, very
Fatty
good.
diet.
Good thinking. Okay, see, fat digestion, for fat digestion, the gallbladder has to release its juice, isn't it? So therefore, so when fatty food ingestion or after fatty food ingestion, the client will be experiencing mainly the symptoms, the pain and all will start, because at that time it has to release, but it is actually affected and it's not able to carry out its actual role. Okay, now therefore when fatty food ingestion, after fatty food ingestion, basically like after, by the time it reaches the intestine, the fatty food, it will take around 2 to 3 hours. Now after intaking fatty food, after 2 or 3 hours, the client will start getting pain. Okay, and that could be a symptom of cholecystitis. And apart from that, the general symptoms will be there, like rebound tenderness, indigestion. Okay, so these problems can also be present, but you should also be noting for some other problems. Okay, so these problems, what are they? What are they? They are biliary symptoms. Okay, you need to note for this biliary symptom, obstruction symptoms. Biliary obstruction in the sense when bile doesn't flow into the intestine, you know, so then what will happen? The fat digestion doesn't happen, isn't it? Rather, the fat will be released or the fat of the food will be mixed in the stool, and the presence of fat in the stool, you will be calling it as clay colored stool. Okay, the stool will be clay colored, steatorrhea. Presence of fat in the stool is steatorrhea. Okay, jaundice, hope you know the reason, because bile is not getting is released properly, so therefore jaundice. Okay, pruritus, accumulation of bile salts, so can lead to itching on the skin, so pruritus. Okay, rebound tenderness, so when that right upper quadrant is pressed, you know, and when you leave your hands, the client will experience pain, so that is rebound tenderness. And apart from that, there is also another sign called as Murphy sign. So this is a classical sign of gallbladder inflammation. Any idea what's this sign? Murphy sign? Yes, Murphy sign in the sense you will when the examiner places the hands on the right side, you know, so and you will ask the client to breathe in. Okay, so the client will when he will not be able to breathe in, so when you palpate deeply, he will be holding his breath, he's not able to do it very fast. Okay, so that is because the gallbladder is inflamed, and when you palpate it, you know, it will go down, it will descend, and that is touching, and that is causing pain. The client is not able to breathe in, okay, while you palpate, or when you palpate, the client will experience breathing difficulty, breathing in is not possible, so that is something we can call it as Murphy sign. Okay, so let me explain once again. So Murphy's sign is nothing but the pain the client or the sign. So for the sign of cholecystitis, wherein the patient will be stopping breathing in, okay, because of when you try to palpate. So that is something we can call it as Murphy sign. Okay, so this Murphy sign is also seen. So these are the very common manifestations. Biliary obstruction signs you need to learn. Okay, like dark urine. The urine color also will be very dark if for cholecystitis, because all the bile salts will have to be filtered by the kidney, and therefore the urine will be dark orange, foamy urine. Okay, apart from that, steatorrhea, clay colored stools, pruritus are all the other or other aspects that you need to know. Okay, yeah. So now here generally you need to understand one thing. For the pain, the client will be experiencing pain, so that is very common. Okay, for pain and all, usually the clients will be on some medications. I mean, for the generally for pain, you can give morphine and all, whereas here specifically, see, opioids are given, whereas specifically morphine and codeine has to be avoided here. Okay, so morphine and codeine is avoided here mainly. It's actually not given because it will cause the spasm of the sphincter in the gallbladder. Okay, so spasm, this morphine and all, you know, so usually morphine sulfate, codeine sulfate are usually avoided. So because they will cause spasm of the sphincter of Oddi. Sphincter of Oddi is the sphincter that will let the so the bile juice flow when fat reaches the intestine. Okay, this sphincter can become spasm if morphine and codeine is given. So morphine, codeine is generally avoided here. Okay, yeah. So apart from that, you need to focus on nausea, vomiting, all those the basic, the general interventions what you carry out. So IV fluids administration, these are the other drugs, chenodeoxylic acid, urosidiol. So these are the other drugs that are usually given here to manage the symptoms. Okay, yeah. So now these are the basic part under the management. Okay, so this come under the initial parts, and now so through these interventions, if there is no success, so then the client will be taken for surgery, so which we can call it as cholecystectomy. Okay, so lithotomy. Lithotomy procedures are basically done when there are stones. Okay, so then apart from that, ERCP, this one, this under this ERCP procedures, what is done? So ERCP, in what else have you seen this ERCP procedure? Any idea? ERCP procedure, when it is done usually? Endoscopic retrograde? Yes. So that is one thing that you have.
Cholangio pancreatography.
Yes, that is one thing, isn't it? So endoscopic retrograde cholangiopancreatography. So this is usually done endoscopic surgeries. Okay, so ERCP procedures. So this is also an endoscopic procedure. So that will help in removing the gallstones also. Okay, so ERCP procedures are done. And then, so shock wave lithotripsy. Lithotripsy is a procedure wherein through the shock waves, okay, so the stones, the gallbladder stones are actually destroyed. Okay, so that is lithotripsy procedure. So we can say. So then intracorporeal lithotripsy. So there are different, like, I mean, so numerous procedures are there. Okay, so intracorporeal in the sense, what do you understand? Intra means something is inserted inside, isn't it? So when stones are there, so what are usually done? So intracorporeal in the sense inside. Okay, so usually I mean, so in this this is also a kind of wherein the procedure that generally an incision is made and the stones are actually visualized and then it is treated. Okay, so that is intracorporeal lithotripsy we say. Cholecystectomy, directly removal of the gallbladder. Okay, so then through surgeries and even the incision is made, and then the holes are removed, the stones are removed. So that is lithotomy. So there are numerous procedures. More commonly, laser procedures are now done. So which is having minimum complications. Okay, so laser procedures are done. But however it is, now post-operative, now if the client has undergone cholecystectomy, the care after this cholecystectomy is very important. Okay, the normal care aspects, you know, like monitoring for infection, maintaining the NPO status, NG tube, and all those are the basic interventions. Okay, apart from that, so the client will be inserted with the tube. So for example, just imagine this is the client and he underwent surgery here. Okay, and he will be inserted with a tube called as T-tube that will help in the drainage of bile. Okay, so that will help in the drainage of bile. So this T-tube, you need to know this. Okay, so T-tube drainage. So what is done here? So these 3 tubes, so we actually remove the gallbladder. Okay, so and after that, so this tube is placed in the common bile duct. Okay, in the common, the duct arises from the liver, into the pancreas, into the gallbladder, and there is a common tract for them, isn't it? So there, this T-tube is actually placed. Okay, so what this will be doing? So this T-tube is put into the bile duct after the surgery, basically. Okay, and so that the it will help in the drainage of the bile. Okay, and after that, after some days, once the tract is all healed, you know, the client will be developing patency without the gallbladder. Okay, so for that we generally insert with a T-tube. Okay, yeah, but care of this T-tube is also very important. You need to know the care of the T-tube. Like usually the client has to be put under semi-Fowler's position during T-tube, and you need to monitor the output amount, color, consistency, order of the drainage. Okay, so this is very important. So do you know any idea about the amount? Amount in the sense maximum 400 ml. Okay, remember the amount is maximum 400 of ml of drainage in the initial 24 hours. Okay, maximum 400 ml. After that, it has to decrease. After that, it has to decrease. Okay, but suddenly if there is, you find very much 500 ml per day, 1000 ml per day and all, so then that has to be reported. Any increase, any sudden increase and all, so that has to be reported. Okay, and always it should be below the level of gallbladder. So this is very important. Avoid irrigation, aspiration, clamping of the tube without prescription. Note this point. You can't clamp without prescription. Clamping has to be done. Why do we clamp? See, the tube has to be removed, isn't it? So as long as the bile flows, the client will not be having any problem. Okay, so after cholecystectomy, after the removal of the gallbladder, so we need to check whether the client is able to tolerate, whether the client experiences any symptoms or not. So because of the removal of this gallbladder, so that is why we clamp the T-tube. Okay, so this T-tube clamping is usually done 1 or 2 hours before meals and also after meals. Okay, so why this clamping is done before and after meals? To assess the tolerance to food after cholecystectomy. Okay, so after cholecystectomy, so you need to understand when the food reaches, the bile duct has to open up and it has to flow, isn't it? Now when gallbladder is not there, the liver, the pancreas will be taking up the role. Okay, now without gallbladder, so when the food reaches the intestine, so whether the client is able to tolerate or is he experiencing any symptoms or not, in order to check that, so we actually clamp the tube, so before and after meals. Okay, so basically to assess the tolerance. If the client is well tolerating, if he's even after clamping, so if he's not experiencing any problem, so then we can eventually remove the tube. Okay, so usually once the drainage and all it gets stopped, so the tube is usually removed. Okay, by the time once the excess drainage is removed, so what will happen? The client will eventually become tolerant to that. Okay, so that is why they are the, so the aspects that you need to remember. So before the gallbladder, before the T-tube is removed. Okay, so remember one point, before T-tube is removed, so you will have to clamp the tube and check for the tolerance. Okay, whether the patient is experiencing any symptoms or not without the drainage. So that tolerance should be checked. Okay, so that is very important here. Okay, yeah. And also you can, as I already told you, you need to clamp the tube before a meal and observe for abdominal discomfort, distension, nausea, chills. And if the client is experiencing this problem, you will have to unclamp. Okay, yeah. So these are the basics about the T-tube and its management. Is that clear? Okay. So next we'll move to the other topic. So that is pancreatitis. So pancreas has got a major role. So what is the role? Two important roles, So when you learn something or inflammation of the pancreas, you need to understand. So all these roles of the pancreas gets affected. Okay. So in the sense, like pancreas has got an exocrine function as well as endocrine function, isn't it? So exocrine function in the sense, so mainly, so the digestion, yeah, it will help.
The enzymes.
It will help in releasing the enzymes. Very good. It will help in digestion. Okay, yeah, digestion of the food. So what about the endocrine function?
Insulin production.
Insulin.
Yeah, it will
Insulin.
help in secreting insulin and also glucagon. Fine. So the pancreatic tissues, so they will keep secreting enzymes. So when food reaches the intestine, the enzymes are sent through this pancreatic duct. Okay, and they will break the carbohydrates, proteins, fats, and all. So that is why pancreas is significant. Fine. Okay. Now, so when pancreas gets inflamed, now based on the location, can you tell me where the pain the client will be experiencing? Where is pancreas located?
The left mitochondria.
Left side, left upper quadrant, isn't it? Okay, so therefore the client will be experiencing where pain? In the left upper quadrant, and it can also reach back. Okay, so that is
to the back.
Yeah. So apart from that, so there are certain other manifestations that you can see in the case of pancreatitis. Acute pancreatitis in the sense all of a sudden when there is some inflammation and all. Okay. Now the client will be having these problems. The pain we already discussed. Okay. So mid-epigastric, left-sided mid-epigastric region, and it will radiate to the back. And this will be aggravated again by fatty meal or alcohol. Okay, alcohol aggravates the symptoms. See, now here in pancreatitis, what is actually happening here? There is autodigestion of the tissues surrounding the pancreas because of these enzymes. Okay, the enzymes escape from the pancreas and it will start digesting the tissues around the pancreas, and through which bleeding will start occurring. So when you observe a client, you can see him having Cullen sign and Turner sign. Cullen sign and Turner sign. What are these signs? They are nothing but, so the bleeding or the exudates, because of the bleeding, so there is discoloration around the umbilical region, and this is Cullen sign. Okay, Turner sign is discoloration in the flank region and all. So you will be fine. This is something we can call it as Turner sign. Discoloration around the umbilical region is Cullen's. Turner's region is Turner sign is discoloration in the flank region. These are one specific sign. Okay, two specific signs. Apart from this, the client can have decreased bowel movement. inflammation causes decreased bowel movement, remember. Then very importantly, you should assess for laboratory test. Laboratory test in the sense, so the client will be having low calcium here. So this is very important. Do you know what is the relation why calcium gets low in pancreatitis? See, there are many suggestions or many people have identified different reasons for hypocalcemia, but actually the reason is not very clear. The hypocalcemia, why it happens in pancreatitis is actually unknown, okay? Whereas several researchers and all, what do they say is, like, because of the autodigestion of the pancreas, you know, the tissues are getting auto-digested, isn't it? So, and they release the fatty acids, okay? So these fatty acids form or bind to the calcium and they get precipitated into the abdomen, okay? So the calcium will be removed because of these because of the autodigestion of the enzymes around the tissues and all. So that is the reason we see. I mean, so many theorists or researchers suggest that is the reason for hypocalcemia. Okay, so you need to know that this laboratory value is important to assess for pancreatitis, that is hypocalcemia. Okay, how do you identify hypocalcemia? See, if the client who is having pancreatitis, if he is having hypercalcemia, that could be something different in the sense yeah, he can also have some other problem if he is having hypercalcemia. Hypocalcemia is hypocalcemia is a very important sign, or the usually the same sign in the case of pancreatitis. Okay, how do you assess for hypocalcemia? So mainly, so you can see as Shostak sign and Turner sign. You know this, isn't it? Shostak sign and Turner sign. So this is Shostak sign. So CH is related to cheek, remember, like that. Okay, Shostak. And this is, sorry, this is Trossio sign. Trossio. Okay, now under introsio, when you tie the BP cuff and when you inflate, if the client is having calcium level low, then there is spasm of his arms. Okay, spasm. It will go like this, spasm. This is Trossio sign. And in Shostak sign, when you tap the facial nerve, you know, it goes to one, there is twitching on the same side. So whichever side you have tapped. So that is Shostak sign. Okay, do you understand? So that is Shostak sign. So please understand. So these, the same symptoms you will be learning in many conditions. Okay, so we learn the same in endocrine disorders and under parathyroid disorders and all, you learn this symptoms, signs and symptoms. So don't forget this. So these are the important signs of hypocalcemia. Apart from that, there will be tremors. They are the added signs you need to know. Okay, so tremors will be there, signs of the tetany and all you need to monitor for. Is that clear? So these are the acute signs that you will be seeing in the case of pancreatitis. Very important. Okay, yeah. And usually painkillers are given, the client will be having severe pain. Painkillers are usually given here, right? So now, in the case of a chronic pancreatitis, so what do you generally see? In the case of chronic pancreatitis, again steatorrhea will be there. Okay, you need to also assess for the symptoms of diabetes mellitus. This is very important because chronic in the sense even the insulin production gets affected. Okay, so therefore when insulin doesn't get produced, the client can experience symptoms of diabetes mellitus. Okay, yeah. So then pancreatic enzymes are given here. So in order to digest, insulin can be given, hypoglycemic agents are given. Okay, and if the client complains of too much of steatorrhea, abdominal distension, cramping and all, so that has to be reported. Okay, yeah. So focus on these aspects. Once again, like the client can be given with all these aspects, okay, like pancreatic enzyme supplements. You need to monitor for hyperglycemia, so you can give your opioids, so you can NG decompression, okay, so NPO, resting of the pancreas. Usually when inflammation, during inflammatory period, you know, resting is basically advised here. You don't give anything orally, okay, so resting is usually advised here. So is that clear? Okay. Yeah, so these are some of the very important points under the pancreatitis. Okay.
Hello, excuse me, I have a question.
Yeah.
The assessment of absence of abdominal sound, is it because of the hypokalemia?
Absence of abdominal sound.
Yeah, you said assessing it, that you have to assess it.
Yeah,
Is it because
yeah,
of the
that is one thing.
hypokalemia?
So when there is hypokalemia, also the abdominal sound, the movement, the bowel movement gets affected. So that is one way. Okay. Yeah.
Thank you.
Yeah, fine. Okay. So next we are moving to discuss some of the basic aspects under hepatitis. Hepatitis is very common, isn't it? So hepatitis, you know, I don't think we need much explanation regarding the same hepatitis. Okay, so hepatitis in the sense, these are the different types of hepatitis, A, B, C, D, E, isn't it? So now what like A is basically, we say A hepatitis in the sense, mainly that causes that is related, or that can occur because of ingestion of contaminated food or water. That's hepatitis A. B is blood, B and C is blood, okay, but C occurs mainly through drug abuse and sexual contact. Fine. Okay, so injection drug users, contact with infected blood, mothers who are born to say children who are born to infected mothers, so all can cause hepatitis B. Okay, so hepatitis D is a co-infection with B. Usually along with B it can be present. Okay, yeah. So now how can you prevent these, or what are the ways? Prevention is basically through vaccinations, but can breastfeeding be done? Can breastfeeding be done for
No.
newborns? No?
Yes.
Yes, breastfeeding is safe. Okay, so breastfeeding is usually safe, so nothing to worry about it. So breastfeeding is usually safe, but what you need to focus is like hepatitis. Apart from the hepatitis B, vaccination has to be given before you start breastfeeding. Okay, so the immunoglobulin, the vaccination has to be given, and after that the breastfeeding can be initiated. Right? But as long as the nipples are intact, there are no crackles and all, breastfeeding can be initiated. It is not of much problem. Fine. Okay. Whereas for HIV infected mothers newborn, you don't breastfeed. Breastfeeding is contraindicated. For hepatitis B, so that's fine. Okay. So within 24 hours, the child will be given with hepatitis B vaccine. Fine. So for and after that, the breastfeeding can be initiated. So that can be considered as the safest tool. Okay. Yeah. So then apart from that, asepsis, what are the other ways how you can prevent? Needleless single dose vials, isn't it? Injections, PPEs, gowns, gloves, goggles appropriately based on the exposure, hand hygiene. Okay. Here also, you know that how it jaundice or hepatitis, what would be the stool color? How would be the stool? Can you tell me?
Clay colored.
How would be the stool? Yes.
Clay colored.
Clay color.
Clay colored stool. Yes, very good. Okay, so now you're understanding how it is related. Okay, so clay colored stool and all can generally you can see there. Fine. So avoiding fat-rich foods. Fine. Okay, so these are checking for the bilirubin levels. Bilirubin levels will be increased there. So these are the different ways how you can actually manage these conditions, right? Okay. So moving to our next topic of discussion. So that is intestinal obstruction. Intestinal obstruction. So what do you understand by this? Intestine is getting obstructed in the sense, what happens here? What could be the reasons? Any idea? What could be the reasons? Yes?
Tumor.
Tumors, very good. Okay, tumors is one of the reason. Fine, apart from that.
Narrowing.
Narrowing, why does it narrow? Because of tumors. Okay, fibrosis. Any fecal impaction is there. What does these pictures show? Any idea? It is nothing but, so this is volvulus, we say, twisting. Volvulus, okay, twisting. Or sometimes intussusception. The bowel segments are getting inside the large bowel. The intussusception. Okay, so through this also, I mean, the intestine gets obstructed. Intestinal obstruction means what? The bowel contents are not moving forward, isn't it? So mainly here, as there are, so tumors and all could be one reason, and also like mainly electrolyte. Here mainly the potassium level. Okay, as you had asked me in the previous topic while I was discussing, potassium level going down will cause low bowel movement. So that's a very important point that you need to remember. Potassium is important for the gastric motility. Okay, yeah. So, and also like suppose during the surgeries and all, if bladder bowel was manipulated and all, so then that could be the other factor. Okay, so what can be done here? So how to manage this condition? Usually the client will be having these assessment findings: colicky, abdominal pain, constipation, vomiting fecal material. Okay, so then children and all can vomit bile, basically vomiting green color vomiters. So that indicates the children, if they are vomiting bile, so that could be intestinal obstruction. Okay, so then an electrolyte imbalance. These are the main manifestations. The important focus should be to checking for the electrolytes and correcting it. Electrolyte, when electrolytes are fine, so usually this problem can be corrected. Okay, so that is very important. So check for dehydration, check for electrolytes and correct. So that is one way through which these conditions can actually be managed. Okay, so intestinal obstruction. These are the ways. So please focus on these points: NG decompression. So monitor for dehydration, check for the stools. Okay, how much like, I mean, so if the client is totally not passing any stools and also all those aspects should be focused in. Okay, yeah. So moving to the next topic, so that is ulcerative colitis and Crohn's. I'd like to discuss this together: Crohn's disease and ulcerative colitis. I'd like to put it together. Okay, so let me also add it here: ulcerative colitis. Okay, because the management and the symptoms are usually the same. Okay, in Crohn's disease and in ulcerative colitis, the symptoms are usually, the management and the symptoms are the same. But what is the difference? Do you know the difference? Do you know the difference? In Crohn's disease, which part is affected?
Small intestine.
Small intestine is mainly affected. So that is ileum. Ileum is mainly affected. But it can happen anywhere. Okay, it can happen anywhere, but very commonly ileum is affected in the case of Crohn's disease. Okay, you need to understand mainly ileum is affected in the case of Crohn's disease. Right? So whereas in ulcerative colitis, basically mainly it affects where? The large intestine. Ulcerative colitis mainly affects the large intestine, in the sense this is, and both are inflammatory process. The symptoms are very similar in both conditions. What could be the symptoms? How do you assess? How do you assess? Yes? Tell me, the clients who are having ulcerative Crohn's disease, how are you going to assess?
Mama.
Yes, they will be having abdominal pain, okay, cramping during bowel movements, weight loss, chronic diarrhea with mucus, okay, chronic diarrhea, electrolyte imbalance, blood and fat increases, enlarged lymph nodes, malnutrition, anemia. Okay, so these are some of the the manifestations that you see. Somebody's talking. Okay, so that you see in the case of ulcerative colitis as well as in Crohn's disease. Severe diarrhea. Okay, so the diarrhea can contain blood, mucus, right? So this is present in the case of ulcerative colitis. Dehydration, electrolyte imbalance, and because of bleeding, the client will also have anemia. Somebody's fine. Okay. Yes. Anybody wants to talk? No, I think so. Yeah. Okay. So now you can do these tests like barium enema, colonoscopy, stool examination tests. Okay. So these tests are done, and these problems can also lead to complications like fistula, malabsorption, obstruction. Okay. So because of the inflammation, so there can be obstruction in the sense like basically when there is too much of ulcerative colitis, so even that can cause a totally limit or the total infection can actually limit the flow also. Okay, in the sense the fecal movements also can be restricted, but very commonly you will be finding this one, diarrhea. Diarrhea is the very common symptom, so that you need to know here, right? Okay, so generally how this condition is managed, in the sense you can provide all the aspects of diarrhea management, that is low residue diet. In those ways, again, you can actually manage the condition. But more commonly, the client will be taken for what surgery? What is that surgery called as? Any idea? What's that surgery? Yes?
Colostomy.
Colostomy. Yeah, stoma is actually made there, isn't it? So that is usually done here. Stoma creation. Now, stoma creation is, again, it depends upon different regions. Okay, so stoma, different regions, in the sense it can be ascending stoma, descending stoma. So based on where the problems are basically seen, okay, so based on that, the regions will actually differ. So I can show you the pictures here, the different regions of stoma. So you need to colostomy, where it is made. Okay, so this is transverse colostomy. Because sometimes when the client is having too much of inflammation from here down in the ulcerative colitis and all, so then the stoma will be made in the transverse region. Okay, so till where the inflammation is in present, at that region stoma is created. Okay, so in Crohn's disease, mainly ileostomy is made. You need to understand ileostomy in the sense like in the ileum, this one is the fecal matter is mainly in the form of fluid, isn't it? So liquid. So you can expect the colostomy bag to be having liquid fecal contents. Okay, so as it enters into the large intestine, only resorption of water, everything takes place, and by the time in the descending colostomy and all, you find more of semi-solid fecal matter. Okay, because the resorption of water and all will be happening here. Okay, so there is a sigmoid. In sigmoid, the fecal matter will be hard. Okay, so sigmoid colostomy. So these are the different areas. Cecostomy, in the cecum region stoma is made, ascending colostomy, transverse colostomy, descending colostomy, sigmoid colostomy. Okay, so these are the regions for stoma or ostomy locations. Okay, is that clear? Yeah. So now, now the client will be having a stoma, but it again depends upon the region, and based on the region, the care also can actually differ here. The care that you generally provide. Okay. Now you need to always. There are certain important points that you need to focus here. First and foremost, the color of stoma. Color. Okay, color is very important. The color has to be pink. Remember, it has to be pink, shining. Okay, so if there is any dull dusk color, it indicates there is decreased, I mean, in the sense like the capillary permeability is reduced. Okay, the circulation is actually reduced. That is what it indicates. The color should be pink to red. Okay, if it is decreasing in color, so then that indicates the perfusion could be actually reduced. Okay, yeah. So now immediately after the surgery, the stool will be liquid, but also you should focus on the food. Food has to be in such a way that, so you should be avoiding gas forming food. Right on this point. Okay, so avoid gas forming foods. And also, but also you provide foods that will help in controlling the udder. Controlling udder, like you can include yogurts, buttermilk. Okay, so when yogurt, buttermilk and all are added, you know, so like some cranberry juice and also that will help in eliminating the odor. But always advise to avoid food that consists of excessive gas, like cabbage, cauliflowers, cucumbers, mushrooms, peas, beans, broccoli. All those should be avoided. Okay, yeah, so these aspects you need to focus under colostomy. Fine. Under ileostomy, mainly the stool will be in the liquid form. I already told you. In the liquid form, the stool will be there. So therefore, so client, you need to monitor for dehydration. In ileostomy, the client should be monitored mainly for dehydration. Is that clear? Okay. So these are the very, very, very important points under the stoma care that you need to focus here. Right? And stoma irrigation also you can get some points. Like under stoma irrigation in the sense, like usually irrigation is done with 500 to 1000 ml of lukewarm water. See, for ileostomy, usually irrigation is not required because always liquid form only the stools are, isn't it? So for ileostomy, irrigation is not actually required. For colostomy only, usually we do irrigation. Okay. Here, you should also instruct about the emptying of the stoma pouch. Do you have any idea like when the stoma pouch has to be emptied?
1/3
When-
full.
1/3 fill. Okay, so usually third to 1/2 or once it's 1/3 fill and all, so the stoma has to be, the pouch has to be empty. Okay, so you should be advising regarding that also. Right, and irrigation should be done daily at the same time. At the same time. Okay, yeah, so on the same time it is generally encouraged. Irrigation is generally encouraged. Okay, yeah, so these were some important aspects under the this one, colostomy and the ulcerative colitis as well as the Crohn's disease. Okay, yeah. So moving to the next condition, so we are going to discuss about diverticulosis and diverticulitis. Have you heard about this? Diverticulosis? What is that? Any idea?
These
Diver
formation of little pouches in the weak areas of intestine
yes,
because of
exactly.
constipation.
Okay. So here, diverticular disease. So this diverticular disease, diverticular, what do you call as, which part is basically called as diverticular? Diverticular. Diverticular in the sense? Yes, tell me.
Descending.
Sigmoidus colon.
Yes, above the, just the sigmoid colon and its above part is usually that we can call it as diverticular. Okay, so diverticular. The left side lower part is called as diverticular. Okay, so this diverticular can get inflamed and also diverticulosis is outpouching, you can say. Okay, so here, so you can see here this left lower part of the large intestine is diverticular. Okay, so now you can, the problems that is experienced here, the signs and symptoms and all are actually the same. Now, in diverticulosis, there is usually outpouching of the intestinal mucosa. Okay, and this diverticulosis can become diverticulitis. So when when the inflammation increases. Okay, so when more diverticula gets affected, so we call it as diverticulitis. Diverticulosis is just the outpouching, what we can say. Okay, yeah. So now based on the region, you need to understand the client will be having where pain. Where would be the pain? The client can experience where the pain?
Left.
Left,
Lower quadrant.
lower
Left
quadrant.
iliac.
Very good. Okay, left lower quadrant. Always the location of pain in gastrointestinal system, it's very, very important. Okay, the pain will be in left lower quadrant. Remember this. Okay, the pain will be usually in left lower quadrant, and as you are due to any straining procedures or cuffing and all, so this pain will generally increase, right? And what else you can expect under the options, under the signs and symptoms, apart from the pain? Anything else? Think. I want you to.
Fever.
Yes.
Melina?
Melina, very good. Okay, so Melina will be there. Anything else? Anything else?
Fever. Low grade fever.
Yes.
Low
What-
grade fever.
Increase in temperature.
Yeah, the client will be having usually diarrhea or constipation, alternating it will be. Okay, so abdominal distension, fever can also happen here, right? Now, I would like to focus, I want you to remember a few aspects very importantly here under the management. Usually, that for this diverticulitis, the client will be on NPO. So always when the symptoms are very severe, we will keep the client on NPO. When the symptoms resolves and all, so when the client is started with foods, so basically we can start with high fiber diet. Please understand the concept, okay? High fiber diet is basically encouraged to increase the bulk and of the stools and just to help in easy movement. Now in diverticulitis, what is happening there? So when seeds and all are there, so when it is taken, so that can, when especially in inflammation, these seeds can block or they can or they can get stuck in this region where the inflammation is there, and that the symptoms can actually worsen. Okay, so therefore, mainly when client is having flaring up of condition, these high fiber foods have to be avoided. Remember, okay, the client will be on NPO when in acute conditions, NPO. Okay, but the client should be avoiding gas forming foods that contain indigestible seeds, nuts and all, especially when inflammation occurs. Okay, generally also the client should be avoided with seeds and nuts. Remember, seeds and nuts should be avoided. Apart from that, the high fiber foods can be given, because seeds and nuts will be lodging in the inflamed regions in the tissues and all, and that's why seeds and nuts should be avoided. But when inflammation occurs, even the high fiber foods should be avoided. Okay, so when the symptoms becomes very severe. Fine. And also these symptoms can actually rupture. I mean, so when the diverticulum is severely inflamed, so it can rupture. When it ruptures, how do you understand if it has ruptured? You need to get back to the signs of the rupture, the peritoneal rupture and all the same signs. Okay, the pain will be spreading across. It will go up. The pain will travel up. And now when inflammation is there, the pain is down, isn't it? So when it ruptures, the pain will go up also. Okay, so those are the ways through which you have to observe for the changes here. Okay, yeah. So then in very severe, as I already told you, you need to assess for perforation, hemorrhage, fistulas and all those things. All straining activities have to be avoided. The client can be put on sigmoid colostomy or descending colostomy and all. Okay, so based on what the client is having, based on that, the client will be on colostomy. Okay, yeah, stoma is actually created. Understood? Okay, colon resection is usually done. sometimes temporary colostomy, sometimes permanent colostomy, depending on what problems the client is experiencing. So based on that colostomy. Okay, yeah. So that was about the diverticulosis and diverticulitis. Okay, yeah. Next, we are moving to this.
How does this Angie suctioning helps in the diverticulitis?
It will help in reducing the distension, abdominal distension. Okay, the distended abdomen gets reduced due to NG suctioning. That's why. Okay, yeah, fine. So moving to the next condition, that is hemorrhoids. Hemorrhoids is something very easy, isn't it? So hemorrhoids, you know what's happening here in hemorrhoids. The veins are actually getting what? In hemorrhoids, what is happening?
Mole in the anus.
Yes, the
Rectal
veins
region.
are dilated here and there is bleeding also. So in hemorrhoids, there is basically bleeding. So how do you identify hemorrhoids? Hemorrhoids during defecation, if bright red, yeah, bright red blood that is seen during defecation indicates hemorrhoids, isn't it? Okay, now how to manage this hemorrhoids? And what are the risk factors? Tell me, what are the risk factors for hemorrhoids? Yes,
Encourage hypertension.
hypertension, especially
Pregnancy.
hypertension. Yes, straining, abdominal pressure, obesity, pregnancy. So these are some of the risk factors. Now you find that the client would be having bleeding with defecation, rectal pain, okay, and even the varicosites, the veins can come out or around the anus. So internal hemorrhoids are there, external and also prolapsed hemorrhoids are there. So internal inside the this one anal region. So external in the sense around the anal region, and prolapsed in the sense you can actually feel the this one the prolapse of the hemorrhoids. Okay, the veins. Now here the management, specifically the client will be put on high fiber diet, stool softeners, bulk laxatives, sitz bath, hazel soaps. Which hazel soaps are there? Okay, so have you heard about this witch hazel soaps? What does this actually do? Yes.
No, ma'am.
Witch hazel soaps? None of you have heard about these? Any idea? What is like? I mean, so in what it is? Like, I mean, so what is the component of this witch hazel soaps? This is basically a kind of when client is having excess of areas that are inflamed, you know, so this will help in cooling. Okay, so that is something we can call it as witch hazel soap. Fine. So if you it is in the form of some wipes or pads, we can say. Fine. So like usually usually or when any irritations are there, you know, so this will generally when you wipe with the hazel soaps, it is available to buy directly, and you can just use that to wiping also. So usually for kids and all it's used. So when they are having too much of fecal incontinence and all, this witch hazel soaps are usually used. Okay, yeah. So then too much of laxatives should be avoided here, so that will cause rupture also. These are certain surgeries, sclerotherapy, circular stapling, band ligation, and all these things. Okay, yeah. But after surgery, remember to advise the client on using both ice packs and sitz bath. Both has to be used. Ice packs will help in decreasing swelling. Sitz bath help in decreasing irritation. It will help in improving circulation, and that's one. Okay, yeah. So these are the ways through which the hemorrhoids are usually managed. Okay, so after the surgeries, right? Okay. Next, we are going to discuss about the last condition for today. So that is appendicitis. Okay, so appendicitis. So appendicitis is, I mean, you know what happens in the appendicitis. Appendix is getting inflamed, isn't it? So the pain will be in different forms, usually in the right lower abdomen. What is that specific point called as? McBurney. Yeah, McBurney's point. Okay, now there the client will experience this, since this McBurney's point come under the right lower quadrant, the more intense pain is actually seen there. And you can also find the client guarding. He will be bending like this, he will be holding like this. Okay, so this appendix can rupture and it can lead to very, very major complications like peritonitis and all. The client can also have diarrhea as well as constipation. Both can alter here. Okay, tachycardia and all these problems are usually seen. Now, depending upon the severity, the suggestion for surgery is recommended. Okay, we do X-rays, ultrasonography, and the severity is identified. And the clients will be on NPO, IV fluids, analgesics, and last appendectomy is usually done. Okay, so there are some pre and post-operative focusing points here before surgery and after surgery. Okay, so these NPO status, GI status are all common, you know already. What are the aspects that you generally do not know? It could be the signs of ruptured appendix and peritonitis. So may I know what are the signs of ruptured appendix and peritonitis? Answer now, we have discussed already there lots of times.
Tachycardia, rigid abdomen.
Very good. Tachycardia, rigid board-like abdomen. How about the bowel sounds? Bowel sounds?
Absent or hypo.
Weak or absent.
Hypoactive. Very good. So will there be rebound tenderness?
Yes.
Yes.
Yes. Okay. So there will be. What about the urine output? Decreased or increased?
Decrease.
Decreased urine output. Okay, yeah. And even sometimes, because the peritoneum, the respiratory, the diaphragm and all are near it, so these peritonitis will inflame the respiratory nerve, the diaphragmatic nerves, and that will cause hiccups. Okay, too much of hiccups also can be seen in the case of ruptured appendix. So you need to monitor for the signs and symptoms of ruptured appendix. That's very, very, very important. Okay, so giving 3 stars for monitoring these aspects. Coming to the next one, positioning will be right sideline, because the client will find some comfort because already the inflammation is towards the right side. So then cold application, no heat application, no laxatives, no enemas. Remember, see, this is very important. Okay, even in diverticulitis and all, we generally don't give enemas. Why? Because this fast intestinal motility will cause rupture. Okay, when motility becomes very fast, you know, so it can rupture the bowel. Okay, so therefore no, and here also the appendix can get ruptured, and therefore no laxatives, no enemas and heat application, but only cold application. Remember this, only cold application for pain. For appendicitis, no enemas, no laxatives, no heat application. Remember these points. Okay, so then post-operatively you need to focus on the all the infection. Always after surgery, monitoring the signs of infection is very common. Okay, then you can give with the dressings. Drainage will be there. The client will usually be on Penrose drainage. Okay, drainage, you need to check for the drainage. Yeah, so these aspects are the other one, and usually the client will be again on right-sided positions itself, isn't it? So right-sided position, NPO maintaining. So are the other aspects. There are some 2 signs also you need to know that will aid in appendicitis. So sign and obturator sign. Okay, so just they will not ask you what is this sign. Just understand that these sign are called as so sign and obturator sign. Okay, so sign and obturator sign. So based on the client is usually the psoas is a group of muscle that is present around the groin region, and thigh region, and when the thigh is flexed, the client will be experiencing pain in the psoas muscle. So that is psoas sign. Okay, so even obturator sign also, this is also a sign of appendicitis. So usually when the right knee is flexed, okay, so the client will be experiencing pain in this region, obturator region. So that is called as obturator sign, right? So these are the other two added signs for appendicitis under the test of appendicitis. That clear? Okay, yeah. So let us move to the questions now. We have come to the end of the session on gastrointestinal disorders. Now let us do a few questions. Okay, fine. So the first question is here. Which prescription should the nurse question when caring for hospitalized client diagnosed with acute diverticulitis? Which prescription should be questioned?
Number 4.
Number 4, very good, quick answer. Okay, we have discussed this, isn't it? So remember, any procedure when there is inflammation, I already told in diverticulitis, in appendicitis and all, where the chances of rupture can happen. So any procedures that will increase these chances of rupture should be avoided, especially during the acute disease process. Okay, see, the same condition, the enema and all can be given if there is no inflammation. Once the inflammation is resolved and all, if the client is ready for discharge, at that time enema can be given. But when during the inflammation process, no enema. So you need to understand how the question is put, whether the client is for discharge or whether the client is admitted for whether he is in his acute phase. So all those aspects you need to be segregating in the questions. That's very important. Okay, so here option 4 is the right answer. What is done in acute diverticulitis? Mainly colon rest till inflammation resolves. That's very important. Antibiotics, Metrogyl, all Ciplox and all can be given. So therefore first option is right. NPO status should be maintained. Third option is right. Okay, so NG suction will help in reducing the abdominal distension, to reduce nausea, vomiting. It is helpful, and even bed rest, IV fluids and all can be given, and therefore option 4 is right answer. Okay, yeah. So moving to the next one. The nurse is providing discharge teaching to a client newly diagnosed with ulcerative colitis. So which of the following statements by the client indicate that teaching has been effective? SATA. Understand the question. The nurse is providing discharge teaching to a client newly diagnosed. Okay, means he is in his inflammation state now. Now, which of the following statements by the client indicates teaching has been effective? I need to eat a diet high in calories and proteins so that I avoid losing weight. Think whether it is important or not. Do you think so? Yes or no?
No, ma'am.
Why? What's wrong? Why did you say no? Yes. Under the dietary, this one, why are you not supposed to give this? Yes, the client is discharge teaching. He is all fine now, isn't it? He is fine. Okay. So whereas he was newly diagnosed, he had that symptoms, acute symptoms were there for the first time. He's fine now and he's getting discharged. Of course, you can resume to eating. If it was an inflammatory phase, no eating. I wanted to know whether you are focusing on this point, that is whether it is discharge teaching or not. Discharge teaching in the sense he's almost fine. Of course, he can get back to his normal food. Okay, he can eat. This is very important to reduce the all the muscle wasting and all. Option 1 is right. Two is also right. Okay, avoiding alcohol beverages is right. 2 liters of water daily and more. Yes, of course it is right. I'll keep a symptom journal to note what I eat and drink during the day. Yes, when he eats what he has symptoms and all, he need to know so that he can avoid those factors. And of course, this is also right. All answers are right here. Okay. Yeah. Any doubts or confusion? Please let me know. The nurse who is caring for a client with acute diverticulitis will immediately report which finding to the HCP. Acute diverticulitis could be reporting which finding to the HCP. One? Yes. Okay, option 1 is the right answer. Why? What does that indicate? What does that indicate? Tell me. No, option 1 is right. What does that indicate? It indicates that? It indicates that? Yes, what?
Peritonitis.
All of it
Pancreatitis.
indicates that there is a rupture.
Pancreatitis.
Okay, yeah. So mostly the left side is affected, and when it is progressing to the left upper quadrant in the sense, so what does that indicate? Like the chances of peritonitis is very high. Okay, so it would have caused the perforation. Okay, so that is why the client is experiencing pain in all the quadrants of abdomen. So then that indicates there is peritonitis, and option, of course, that is very, very, very important. So whereas other options, if you see for clients, hemoglobin, okay, that's fine. This is also fine. That will help in relieving the pain. This position lying on side with knees drawn up. WBC 12,000, of course, he's having inflammation, right? So WBC is an expected aspect, whereas this is not expected one. Okay, so therefore, so if you find something not expected, see how you should distinguish NCLEX answers. So you need to check when certain conditions are given here, you know, you need to check in the options whether they are the options which are existing in those conditions or not. Whether they are expected or not, you need to understand. Okay, so expected ones you can eliminate. Is there anything which is there any symptom which is not supposed to happen, or is there any symptom here, so which if it occurs, that can indicate some complication? You need to think in that way. If you think only about the symptoms, yes, WBC is a concern, but since it is diverticulitis, this is an expected sign. Okay, so therefore, whereas this is not expected, and if you find this, that indicates there is peritonitis, and therefore, so this has to be reported. Is that clear? Okay, because I found some of you giving answer as 4 also. So therefore, I wanted to make sure clear about these aspects. Okay, moving to the next one. After performing a physical assessment and obtaining vital signs for a client immediately after laparoscopic cholecystectomy, which nursing intervention is the priority? So which is the priority intervention? Laparoscopic it is. Priority goes for? Yes? This is an easy question, isn't it? Early ambulation, exactly. The priority goes for early ambulation, especially after laparoscopic. cholecystectomy. What involves in this procedure? Usually in this procedure, so in laparoscopic procedures and all, mainly the client is introduced with carbon dioxide and all, so that the abdomen is clearly seen during the laparoscopic procedure. So after the procedure, you need to push out that carbon dioxide out from the body. Okay, that is one reason. And also to prevent the complications of thromboembolism, decreased peristaltic movement and all, you should make the client walk. Okay, anti-embolism stockings is important, and stool softeners and all are also important. Okay, so whereas early ambulation will reduce the risk of thromboembolism. Okay, so then anti-embolism stock, this is important, but early ambulation will reduce the risk of getting this. So under prevention, this has to be under prevention, this goes as the main answer. Okay, so therefore option 2 is considered as the right answer. Okay, so these questions we had done. Moving to the next one. Yeah, these are exhibit kind of questions. The nurse is caring for a client with acute diverticulitis who has nausea, vomiting, and rates pain as 8 on a scale of 0 to 10. Which of the following interventions should be included in the plan of care? SATA. See here, you find that the temperature is 101.2, diverticulitis, okay? Yeah, and he has nausea, vomiting, pain is high. Now what should you do? Blood pressure is 126, heart rate is 102, respiration 20. Now what you should do? Are you going to give morphine? Are you going to insert a rectal tube to protect the client's skin from diarrhea? Are you going to instruct the client to avoid straining? Or are you going to maintain the NPO status? And this is the 5th one, okay? Start IV infusion of normal saline. So what are you going to do here? So that is the question. What are all right? Option 1 is right? Yes, okay. So option 1 can be given. Okay, mainly morphine is avoided in which condition did I say? Mainly morphine is not given in which condition?
Cholecystitis.
Cholecystitis, okay. So apart from that, morphine is considered as fine. Okay, so option 1 is right. What about option 2? When you insert something to the rectum, see what will happen. Can you do that when there is inflammation? The client is already having the inflammation.
No.
Can you do that? No.
No.
Okay, you not even colonoscope, not even rectal thermometer, not even sigmoidoscope, nothing can be inserted. Okay, so because it will cause perforation, the rectum will get stimulated and it will cause perforation. So no option 2. What about the third option? Yes or no?
Yes.
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 NPO status? Yes. IV infusion of normal saline?
Yes.
Okay, yeah. So therefore, apart from the second option, so all other options are right. Okay, under diverticulitis, please make sure that you need to avoid anything that will cause perforation. Okay, and also avoid high fiber, indigestible roughage food when there is inflammation. Okay, avoid this. Generally, you can give high fiber food after the inflammation resolves, but when there is inflammation mainly, so it's better to avoid seeds, nuts, and all. Okay, yeah. This we had discussed. Okay, something on hepatitis. Which nursing interventions would the nurse implement when caring for a client newly diagnosed with viral hepatitis B? Viral hepatitis B.
One, two, four, five.
1, 2, 4, 5. Yes, very good. Okay, yeah. So except diet high in fat, we can provide all the interventions. Okay, very good. This was very simple. Okay, this we have done. Which statement made by the client demonstrates a correct understanding of the home care of an ascending colostomy? Ascending colostomy means what? Do you remember the picture that I had shown? Ascending. So this is ascending. This is descending. This is transverse. So this is sigmoid. This is ileostomy. The question is, which statement made by the client demonstrates a correct understanding of the home care of an ascending colostomy? I will avoid eating food such as broccoli, cauliflower. I'll empty the pouch when it is 1/2 full of stool. I'll irrigate the colostomy to promote regular bowel movements. I will restrict my fluid intake to 2000 ml of fluid a day. Correct understanding of the home care of an ascending colostomy is the question.
1.
1. Yes, that is right, isn't it? So that's actually,
Avoid forming food.
yeah, that has to be avoided. Okay, so now what about this one? I will empty the pouch when it is 1/2 full of stool. So usually
It should be 1/3.
yeah, 1/3. Okay, so I mean, so 1/2 before 1/2. I mean, so or 1/3 when it's 1/3 itself, if you empty, so what will happen there? So when it's emptied 1/3 filled, then further this one leaking can be prevented. Okay, so therefore 1/3. So that's the right answer. Okay, yeah. So see, there are different questions in here in these ways itself. When you in the Canvas, when you do the questions, you might find confusing. Please note how the options are given, and still if you are confused, take a screenshot and send me or put me or in the via Teams. You can just ask me to explain the same. Okay, so I will be helping you out in clarifying the doubts via Teams. Right? Okay. So therefore here option 1 is the right answer. So I will irrigate the colostomy to promote regular bowel movements. Why it is not considered as the right answer? Why it is not considered as the right answer?
Because it should not be irrigated regularly.
Ascending, isn't it? The stool in ascending and all, stool is usually semi-liquid, liquid form. It doesn't require irrigation. Usually irrigation is required for sigmoid and descending colostomies. Okay, yeah, so therefore 3 is not the right answer. I'll restrict my fluid intake to 2000 ml of fluid per day. So this is also not right. Why is it so? At least 3 liters in a day you should provide, because ascending in the sense the client, we discussed that, isn't it? So especially for ascending or ileostomy and all, more fluids have to be given, because the stool itself, there is no water resorption. In normal people, so usually the intestine, the large intestine resorbs water. So for us, like 2 to 3 liters could be fine, whereas for people who have undergone ascending colostomy, ileostomy and all, so at least 3 liters per day should be provided. Otherwise, there could be chances of dehydration. Okay, yeah. Yeah, the next one. The nurse provides discharge instructions to a client 1 day after laparoscopic cholecystectomy. Which statement by the client indicates that further teaching is avoided? Broccoli causes gas. That's why, okay? Yeah. Answer? 1 day. Further teaching in the sense something is wrong that is said by the client. What is that?
4.
4.
4? Okay, 4. Why is it wrong?
It is recommended to take shower instead of bath.
Yes, not bath. Okay, so you can allow them to have a shard, like bath in the sense only after incisions are healed, baths are recommended. Okay, total after complete healing, baths are recommended. Okay, so not just soon after the surgery. The clients can just have a shower, not bath. Fine. So therefore, fourth one is considered as a right answer here. So that requires further teaching. Okay, others are actually right. Right? Okay. Moving to the next one. The nurse is caring for a client with end-stage liver failure from hepatitis C who is being seen in the clinic for worsening ascites. The client is treated in the infusion center with albumin, furosemide, spironolactone. The following day, the nurse checks the client's lab. Which of the following lab findings is most important for the nurse to communicate to the healthcare provider? What is the most important? Which is out of normal range?
Potassium.
Potassium is low here, isn't it? Okay, so the client is experiencing hypokalemia, and that could be because of using furosemide. The client is on furosemide, isn't it? So now if potassium is decreased, what will happen? The potassium is,
Arrhythmia.
yeah, it will, potassium, if it is decreased, it will cause arrhythmia, as well as it will cause encephalopathy also. Okay, so the hepatic encephalopathy can also, he's at risk of developing hepatic encephalopathy. So when potassium level is low. So therefore, so potassium is considered as the right answer. So not sodium, okay, potassium. Fine. Okay, guys, so that was all about today's session. So any doubts you are having? Was it clear? Any doubts for further clarification? Yes, while you do questions, you might get doubts. After reading rationalize, if you don't understand, so make sure that you get back to me. Okay? Yeah, I'm happy to answer your queries. Okay then, so see you. Take care. Bye. Good night.